and the rain still continues, okay? And everything has come down. AQI, which had crossed 460, is now back to 200.
Okay. So it is more reassuring now.
No, the artificial rain was supposed to be
started joining.
Conducted on 25th. But before that only, nature God has been kind enough and bestowed with a shower. Good evening, Dr. Vijayan.
Good evening, Dr. Anirban. How are you?
I'm absolutely fine. Great to see you.
Yeah.
A long time back to India.
I was on a sabbatical and rejoined last week.
Yeah, so great to see Deepak back to India, taking on the mantle of intensive care in our region.
Anyway, last 1 year was a sort of vacation for me. It was a very good exposure there in UAE.
But with this thing, the Gulf thing, there is no effect on the UAE, na? More or less.
No, nothing.
And with that Qatar, that 8 Indians being given death sentence, that also has made no difference, I guess.
Nothing, because in UAE the rules are very strict. You cannot even poke your nose into anything unnecessary. You cannot even discuss those things in the public there.
Oh, okay. Oh, very nice.
But now back channel efforts are being made to secure their release.
Yes.
So how confident are we, Anirban, that we would succeed in all this?
I think they are pretty confident. Good evening, Dr. Ramesh.
Good evening, sir.
Great to see you in GICS Rapid Review.
Namaskara, Ramesh.
Namaskaram.
Ramesh is from Karnataka.
Oh, I didn't know that.
Continental Hospital, Hyderabad.
Yeah, but he has found green pastures in Hyderabad, so he decided to settle there.
Hyderabad is greener in comparison to
He has found much greener pastures.
Yes. Found the spots.
Greener than Hyderabad. Your participants are.
Every place has green spots to search.
Yes.
Investigative, not journalism, investigative, intensive.
So
it's 6:59, and I think the clock will now start moving. The countdown will begin, right, Shabina?
Sure.
So, Shabina, you want to wait for 2 minutes or just start off the countdown? It's around 30 people have logged in.
30? Not bad. For a
Wait for 2 minutes.
holiday.
1 minute for doctor.
Yeah, 2 minutes. I think Anirban will be kind enough to give 2 minutes.
Yes,
Anirban?
definitely. I will kind enough to give 2 minutes and take 5 minutes from your busy schedule at the end of the show. So how is the market, Pradeep? It's bringing smiles all across.
Market has been up and down like human behavior. Like human behavior, it has. Yeah, so it has its heyday and a grey day.
How do you feel is the BSE, Bombay Stock BSE?
Hi.
Share ID.
Good. I think I exited BSC some time ago with a good profit.
And
I think, like in life, in stocks, you should not have any attachment on it.
Yes, no attachment, no aversion.
Yes. You have attachment, that's when the grief starts.
And what about keep it?
So, Ramesh, are you in stocks? Ramesh or Deepak, anyone else in stock market?
I am there, sir, but rarely. I think 3-4 stocks are there in my Zerodha account.
Very good.
Previously, I used to do, but now I'm not getting that much time to see.
Yeah. Good.
But mutual funds, I'm there.
Yes, very important.
What about Senco Gold, Pradeep sir?
Sorry?
Senco Gold.
I didn't hear properly. Anyway, it's starting now.
Yeah. Good evening, friends. welcome you back to yet another brand new episode of GICS Rapid Journal Review. Tonight, we are going to discuss on a subject which is intrigued by its complexities and which brings paradox when we think about septic shock. Yes, it is about the use of beta blockers. And before we hear about the study which has been published recently in the JAMA, the Stress L study by Dr. Ajmal Abdul Karim, which will be moderated by Dr. Deepak Vijayan, I want to introduce you with our regular panelists, Dr. Ajit and Dr. Pradeep from Bangalore. And we also want to introduce our expert panelist today from Hyderabad, Dr. Ramesh. Welcome you, Dr. Ramesh, Dr. Pradeep, Dr. Ajit, Dr. Deepak Vijayan, and Dr. Ajmal. So before we hear, we are going to get a brief idea about the use of beta blockers in critically ill. And after that, the study will be presented by Dr. Ajmal. Dr. Pradeep, please.
Thank you, Anirban. I think Shabina and Vinay, you can just take me to the screen presentation. Good evening, friends. So I'll be talking on this topic, beta blockers in ICU. So I'll be giving a brief overview. This is in the context of the journal review, the journal that is going to be presented, which is Landalol in intensive care. So this is a stress health study which came in JAMA. So just to create a context for that, it is imperative that we understand what are all the previous studies that have happened in this dimension about the role of beta blockers in ICU. So most listeners, you would know beta blockers are favorable in acutely ill patients. And beta blockers in ICU is a very big topic. So there are multiple conditions where beta blockers have found to be beneficial. So like beta blockers in traumatic brain injury, there is a distinctive role, so which I'll be doing a separate video. So today I'll be more focusing on beta blockers in sepsis and the number of studies that have happened. And there is a role of beta blockers in burns patient also, so on and so forth, so which I'll talk later. So why beta blockers in ICU? So when we have these patients with sepsis, and so there are three sort of receptors that can get activated, and that is where the whole role of beta blockers come in play. So in sepsis, we all understand there is a catecholamine surge and there is a cytokine storm that happens, and there's a release of lot of pro-inflammatory cytokines. And beta blockers has a role in mitigating this storm and this effect of these pro-inflammatory cytokines. So there is increase in the tumor necrosis factor alpha, interleukin 1 beta, interleukin 6. So we know this, that there's a whole lot of inflammatory mediators that get released in cytokine storm, and these levels tend to increase. And there is activation of both alpha and beta receptors following this storm that happens. And this activation of both these receptors, alpha and beta, leads to platelet aggregation. And so there can be platelet aggregation, and there's a lot of endothelium injury that happens, and they become very leaky, which we know that happens. And this gets perpetuated by activation of these receptors. And because of these platelet clumps that forms and leaky endothelium or injured endothelium, there is microthrombi formation also that happens. So obviously, it is purported or hypothesized that the role of beta blockers in having effect on these receptors may have a favorable outcome. Then the activation of alpha receptors that happen in sepsis causes vasoconstriction. And because there is a vasoconstriction, there can be pulmonary venous constriction, and pulmonary capillary pressure tends to go up. The hydrostatic pressure goes up, and there is perpetuation of edema formation within the lungs. So they can have ARDS, ALI, pulmonary edema, so on and so forth. So this happens with the activation of alpha receptors. Then now we're more interested in beta. So the activation of beta receptors leads to myocardial injury. Myocardial dysfunction can happen because of the storm that happens. There can be myocardial necrosis, and we know there is a distinct entity called septic cardiomyopathy where myocardial dysfunction happens. And this happens due to overt activation of the beta receptors. So there is myocardial necrosis, and there can be left ventricular failure or cardiorespiratory dysfunction that sets in. So this is the sort of conundrum that can happen with activation of various receptors in sepsis. And the hypothesis is that beta blockers may have favorable effect by mitigating the effect of these activation of these receptors. So what really happens in sepsis? So in sepsis, we know that there is tachycardia. So why tachycardia? This is a natural sort of a adaptability by the body to improve the cardiac output in sepsis. So increased heart rate, there's increased cardiac output. And why cardiac output increases? It's an intent to increase the oxygen delivery. So there is increase in the oxygen delivery. And so this whole process, because there is overt tachycardia, there is some sort of a coronary hypoperfusion also that sets in. So all this is a protective natural mechanism that tends to happen. So then why beta blockers? So with the use of beta blocker, so our effort is to minimize the heart rate. So our intent would be to reduce the heart rate and reduce the myocardial oxygen consumption. So I'm sure most listeners would appreciate this, that by in heart failure or in cardiac condition, our intent is to reduce the heart rate so that the myocardial oxygen demand comes down and oxygen consumption is reduced, and there is more time for diastolic filling. So there is reduction in the diastolic filling time. So that we give more time for the diastolic filling and improve the coronary perfusion. So this is our sort of conceptual understanding as to why we would want to slower the heart rate in sepsis. So this is our understanding, and this is where the science of whether there is any role in the use of beta blocker in sepsis comes. And our whole intent is by reducing the heart rate, reducing the myocardial oxygen consumption, and reducing the diastolic filling time. So, and improving the coronary perfusion. Our intent is to reduce the risk of myocardial ischemia and optimize the favorable outcome. So this is our conceptual understanding. So now we look into the evidence. When you look into the evidence, so it all started in 1972 with a case series where they used beta blockers in refractory septic shock, where they found some hemodynamic favorable effect of propranolol. After that, there were multiple studies. So if you look into this, dig into this literature, there are truckloads of studies with regards to role of beta blockers in critical care. Today, I'll focus more on sepsis, and maybe in the subsequent video, I will do role of beta blockers in traumatic brain injury. So when you look at evidence, evidence is limited to case series. Then there are a lot of retrospective and prospective observational studies. So I'll just give an overview of 5 retrospective and prospective observational studies. Then there are about at least 8 randomized controlled trials of the role of beta blockers in sepsis. And once you have randomized, then you'll have meta-analysis. There are around 4 meta-analyses which have been published looking at the role of beta blockers in sepsis. So this was the study that came early on in 2008. This was a observational study by the Austrian group, Schmittinger et al., where they looked at 40 patients, and they looked at whether beta blockers was effective in controlling the heart rate, maintaining at 65 to 95 beats per minute. And out of 40, in 39 patients with the use of beta blocker, they could have a very good control on heart rate. And what they also found with the use of beta blockers, they found the stroke volume index also was significantly increased. So which means they had a favorable effect on improving the cardiac output. And what they surprisingly saw in this study was the need for norepinephrine, vasopressin, and milrinone requirement significantly reduced when beta blockers was used in sepsis patients. So this was an observational study. So after that, there were a lot of prospective observational studies that happened that looked into cardiac output, whether beta blocker had a favorable effect on cardiac output. So Gore and Wolf et al., US group, they saw that with use of beta blocker, the cardiac output reduced proportionately in relation to the heart rate. So Morelli et al. Was the Italian group where they said the use of beta blockers really did not change the cardiac output. Then there was a paradigm shift. So Balik et al. This is from the Czechoslovakian group, where they showed cardiac output did come down, but it did not have any significant impact. But then this particular study, observational study from Chinese, Liu et al., they showed that on the contrary, use of beta blockers increased the stroke volume, like Schmittinger, who showed increase. So there was increase in the stroke volume. And this happened more so with ultra short acting beta blockers like esmolol. So that's when the whole shift happened with the use of ultra short acting beta blockers like esmolol, where they said the esmolol really did not have an impact on reducing the cardiac output. And after this, there was another study by Shang et al. In 2016, where they showed that use of esmolol, which is an ultra short-acting beta blocker in sepsis, reduced the duration of mechanical ventilation also. So they started seeing favorable effects with the use of ultra short-acting beta blockers in sepsis. So, but these studies, as I said, are retrospective and observational studies. They were small sample size, and the outcomes, the clinical outcomes that were looked at were little uncertain. Then they had to resort to doing randomized controlled trials. Although observational studies showed signals toward favorable effect, they had to do randomized controlled trials. So this was the first randomized trial that came, esmolol in septic shock, Morelli et al., again by the Italian group, published in JAMA in 2013, where they looked at 154 patients randomized between standard group and esmolol group. And they found that heart rate control with the use of esmolol happened very well, and they could maintain good heart rate at 80 to 94 beats per minute. Median reduction of the heart rate was 18 beats per minute with the use of esmolol, and that was statistically significant. And even in this study, right, which is a randomized control trial, they showed that stroke volume and left ventricular stroke work index significantly increased in the esmolol group when compared to standard group. And again, like the Schmidt, which showed the observational study by Austin Group, Schmittinger, norepinephrine need and the fluid resuscitation, the fluid requirement also significantly decreased with the esmolol group. So, which showed use of esmolol had a favorable effect in this randomized control trial. And they also showed that pH, lactate, and base excess improved with the use of esmolol as compared. So this was a randomized control trial published in 2013 JAMA. We showed favorable effects with the usage of ultra short-acting beta blockers esmolol on the outcomes. After this, there were about 7 randomized control trials, and surprisingly, a significant proportion of them came from China. So these are all the studies. So I won't go into the details because these are all small randomized. The first one was from Belgium. And if you see all the subsequent ones, 5 of randomized control trials came from China in a very non-specific or not a high impact journals. And then there was one randomized control trial that came from Japan, published in 2020 in Lancet Respiratory, which was the first sort of a pilot study with the use of landolol. Landolol is like esmolol, which is an ultra short-acting beta blocker, on which subsequently you will hear about the journal presentation on that, which was published in JAMA. So Kakihana, so these were the randomized. So now you had 8 randomized control trials, following which then the meta-analysis came. So the first meta-analysis was from Chaco et al., published in 2015 by the UK group. They took all the 9 studies and they showed when they put all the studies together, the use of beta blocker showed benefit with reducing the heart rate and reducing the mortality and improving the acid base. So they showed all favorable effect with the use of beta blockers. After this, then the San Filippo et al. Was another meta-analysis that came in 2015. Again showed similar signals. Use of beta blocker showed benefit with reducing the heart rate, and there was no serious adverse events. So then there was this another randomized meta-analysis which came, Liu et al., where they took 5 randomized controlled trials where only esmolol was used, because these 2 randomized controlled trials used all the beta blockers. So Liu et al. Did a meta-analysis with only studies which used esmolol, 5 randomized controlled trials. And if you see the survival rate in sepsis when esmolol was used, the relative risk was 2.06 and it was statistically significant, which means it had a very favorable effect on the survival. The use of esmolol in sepsis, septic shock had a favorable effect on survival. But when they looked at the hemodynamic parameters like CVP, mean arterial pressure, mixed venous oxygen, there was no difference. Then after that, there was another meta-analysis by Lee et al., again with esmolol from US group, 5 randomized control trial with 14 studies. So esmolol showed favorable outcomes with odds ratio of 0.407 and which was statistically significant. So these meta-analysis, all the 5 meta-analysis which I've showed strong signals towards favorable outcome with the use of beta blockers. More so, the effect was profound with the use of ultra short acting esmolol. The Lee et al. And Liu et al. Both showed favorable effect with the survival with the use of esmolol. So this is about the current evidence with regards to beta blockers. So now the question is, in ICU, in sepsis, many patients do develop atrial fibrillation. So these were 2 good studies. So as you see, this was published in CHEST in 2016. In atrial fibrillation, they did a propensity match cohort study, which was published in 2016 on the role of beta blockers. Here they compared whether beta blockers were superior to digoxin, calcium channel blocker, or amiodarone. So they looked at whether beta blocker versus CCB digoxin, and they found that the beta blocker had better effect in reducing the hospital mortality, especially when the heart rate was maintained less than 110 beats per minute. So this was also very provocative to say that beta blockers had much more profound effect when compared to calcium channel blocker, digoxin, and amiodarone with regards to reducing the heart rate and improving the clinical outcomes. And this particular study, which I said, which was the first pilot study where they used Landolol. This is a Japanese randomized controlled trial. They did in with use of Landiolol, and the subsequent talk will be on that, where they showed there was a significant reduction in the heart rate and reduction in the new onset arrhythmias with the use of this Landiolol. So that is about in atrial fibrillation. So going forward, so Hosegawa et al., who's again a Japanese, did a meta-analysis with usage of ultra-short-acting beta blockers, which is esmolol or landolol. So they took 7 randomized controlled trial and to maintain heart rate less than 95 beats per minute. And this was a study using only ultra-short-acting beta blockers, 572 patients, and they found that 28-day mortality was significantly less when ultra-short-acting beta blocker. Again, re-emphasizing what Liu and Lee showed, that with the use of esmolol, there was a profound effect in improving favorable outcome. This was re-emphasized with this meta-analysis by Hosegawa et al., where 28-day mortality was significantly less when ultra-short-acting beta blockers were used. And this was statistically significant. And here they went on to show the absolute risk reduction was 18.2%. Number needed to treat was 6, means they had to treat 6 patients to save 1 life. So that was the meaning of that. So which was also very profound and provocative sort of a finding they found. So all in all, if you see, it all started with a case series in 1972, then went on to show the prospective observational studies, which again showed signals towards favorable benefit. Then came the randomized controlled trials. So that one randomized controlled trials with 150 patients showed a strong signal again towards favorable outcomes with use of beta blockers. And then there was series of randomized controlled trials by the Chinese groups, followed by meta-analysis, which again point out that the effect was more profound with the usage of ultra-short-acting like esmolol. And then subsequently, Japanese did a trial with landiolol, where again they showed favorable effect. And the meta-analysis by the Japanese group also showed favorable. So all in all, you see a robust sort of an evidence building with the use of beta blockers, then moving on to more of ultra short acting having better impact. So this is the sort of evidence we've had. Then the question remains, how about patients who are already on beta blockers? So this is no brainer. I'm sure every listener would know someone who is on previously beta blocker have a favorable effect with regards to outcome when they get admitted to ICU. We know that. But just to recap our evidence, so this was a study, Mathieu et al. This is the largest sort of a study where they looked at 9,465 patients who were on previously beta blockers for various reasons, and they found that in these patients, when they get admitted to ICU sepsis, their mortality was significantly less. And Singer et al. Again showed in 2017, if someone is on beta blockers already, when they get admitted to ICU, their hospital mortality is less and 30-day mortality also is less. Tan et al. Again showed the same thing. Someone who's on pre-morbid beta blockers, their mortality is lesser compared to the patients who would not have been on beta blockers in ICU setting. And Guz et al., this is from Israeli group. So there they pointed out that cardioselective beta blockers were more protective, like metoprolol or esmolol, so on and so forth, which are more cardioselective or more protective than beta blockers, which have effect on alpha also. So that is the sort of a message that came out from this particular study. So now the question is, how about if someone is on beta blockers before, would then one continue on beta blockers if they come to ICU? So that came from this trial by Fox et al. This was a prospective observational study from Germany, which again says if someone was already in beta blocker, generally the tendency is when they come to ICU, we stop the beta blocker. So the question is whether should we continue. So that came from this study. They looked at 296 patients where they continue using beta blockers when they get admitted to ICU. In 167 patients, they continued usage of beta blocker. So the 28-day and 90-day mortality was significantly less in the group where they continued beta blocker as opposed to stopping them. as compared to where the group where they had stopped, and that was statistically significant. And even they found in this study, the fluid requirement also was significantly less. As you see, the P was significant. So this goes on to show, so until now, whatever I've spoken, there is a compelling background body of evidence which point towards favorable outcome with the use of beta blockers, continuing it in ICU, and the ultra short acting beta blocker seems to have more profound effect in at least the meta-analysis and by this Japanese group, which again did the meta-analysis and Landolol pilot study. But the current study, which will be discussed, obviously it was a negative trial, but we have to keep in the background all the studies that have evolved over many years, which shows very provocative message or a signal towards favorable effect of beta blockers. And esmolol is the most studied drug. For all the trainees, the dosage that is being used is 0.05 mg per kg per minute. So if you are dealing with a 60 kg, it is 3 milligram per minute. And over hour, it is around 16 mg to 25 mg per hour. That is the sort of infusion that one could consider using esmolol in ICU. And the targets when you use esmolol is to reduce the heart rate by 20% or keep heart rate between 70 to 95 or 100. Because as you see in the study, most studies try to maintain at around 95 or less than 95. So this is the sort of evidence on the background that we have. And this is a context setting for this new study that is come, special study which was published in JAMA. So that's about the evidence. So maybe in the next video, I will talk about the role of beta blockers in traumatic brain injury, because that is also a big sort of a body of evidence that is evolved. So I'll talk on that. So thank you one and all. So I request all the listeners to present your valuable work or Journal of Acute Care.
Thank you, Dr.
And
Pradeep.
you can visit my website www.pradeepnagappa.com to rehear to this lecture. So thank you one and all.
Thank you, Pradeep. So long you are listening to the use of beta blocker in ICU with the focus being on septic shock, atrial fibrillation, and the like. Now we are going to hear through the study, the stressor study published in the JAMA from Dr. Ajmal Abdul Karim, which will be moderated by Dr. Deepak Vijay. Dr. Ajmal, please.
Hello.
Yes,
yes,
please
sir.
go ahead.
First and foremost, greeting to one and all, and thank you for taking the time to join us in this forum as we deliberate in the earnest on the latest research. More importantly, it is application of a daily practice. I am indeed honored and privileged to have been given the opportunity to present in the august presence of luminaries of critical care. Without much delay, I would like to start the presentation. So I'm taking to the study, the stress L, the study in the reversal of septic shock with Landolol. We'll review that. What is the need for that study? We know septic shock mortality is of 38% and is autonomic dysfunction in the sepsis and non-epinephrine associated immune suppression got poor outcomes. Here, sympathetic overstimulation lead to impaired ventricular-atrial coupling, thereby reducing the systolic duration and increasing the myocardial oxygen demand. There are these positive studies, so much Praveen sir was discussing, a lot of positive studies was there, and from animal studies was there regarding the immunomodulation by reducing the pro-inflammatory cytokines, thereby showing the prolonged survival time of the animals. So with that, what is this trial drug? Landolol. This is new drug, this ultra short acting beta blockers. Its half-life is around 2 to 4 minutes. So that if any adverse effect, we can minimize this dose and we can nullify this effect also. It is more beta-1 selective in 8 times more than esmolol. It is unaffected by liver impairment, so we can very well safely use in liver impaired patient. One and important thing we can use in OAD patient, does not cause any exacerbation in hyperactive airway. It's since 2002 in Japan, it is approved for pre-operative tachyarrhythmias. It is not available in India. but it's available abroad. It came in 50 ml vial with 300 mg. So we have to be cautious in administering with verapamil in atrioventricular conduction abnormality, and we have to be cautious in administering with dexmedetomidine infusion because it may mark hypotension and severe bradycardia may be presented. So we will also cautious in patients who are getting sessamethodium. It may decrease in metabolism and enhance bradycardia. Maximum recommended daily dose is recommended 57.6 mg per kg, and there is no data for pregnancy. So clinical question they raised in the trial is tachycardia and septic shock who are treated with high dose of non-epileptic with the use of beta blocker up to 14 days, reduce the organ failure compared to standard care. So this they have conducted in UK over 40 NHS hospital. The study duration was from April 2018 to December 2001. Due to COVID pandemic, there was a halt from March to August 2020. Chief investigator was Dr. Tony Whitehouse and is being funded by NIHR's Efficiency and Mechanical Evaluation on UK. Sponsored by NHS Foundation Trust. So coming to study design and how they actually analyze the study. Again, it is open labeled, parallel group and phase 2B because it's a new drug we are going to phase the efficacy. Because it is open, non-binded, there is no placebo. So there is no blinded in this because we have to titrate the drug according to the heart rate. So there is no point of blinding this thing. And the allocations was randomization perfect with using computer-traced randomized system by allocating 1:1 ratio. Analysis conducted accordingly intentionally treat. They followed a consolidated console guidelines. This is a newer thing, and so that data are collected accordingly. The power of the study, to keep the power of the study more than 90 with the 3% withdrawal, taking as a means of in a 14-day average was 6.3. To look the difference between 1 point between the beta blocker and the control, they have to take a sample of 340. And they, for looking the treatment effect, the regression model was used and mortality outcome they had carried out Kaplan-Meier plot and proportional odds assumption. So looking the severity of shock from the primary outcome, they have done a logistic regression also. So this is the inclusion criteria. See, we can see the inclusion, they have put all the age above 18 years admitted in the critical care ICU, where sepsis is clearly defined by sepsis 3 definition. And they should receiving a vasopressor support to maintain a target beat of more than 24 hours, and heart rate of during admission or randomization should be more than 95. And that NORAD has been getting at a rate of 0.0 micrograms per kg per minute at the randomization. What is happened if the drug is stopped in between? Suppose that the vasopressor is stopped within 12 days and restarted. In that scenario, they have restarted within 12 days from the starting, the 24 hours starts from the beginning of the vasopressor, first dose they take. Suppose they have started and stopped after 74 hours, then after the 74 hours, when this begins, then that will take us a 24-hour window. Okay, then this after 24 hours of this NORAD requirement have been included in the randomization. Suppose the patient have AF, they have treated with landiolol or potassium or magnesium or amiodarone, but no beta blockers have taken. If his beta blockers is taken for AF treatment, they have been not eligible for randomization and put game into study. With that, they have excluded a lot of categories like the patient with heart block, OAD, the patient with CVA, pregnancy, and the patients having tachycardia for other reasons, and the other form of shocks have been excluded from the study. The primary objective they are to assess the efficiency and tolerability and safety of the beta blockers of septic shock requiring high vasopressor support. The primary endpoint was SOFA score on ICU admission after randomization of maximum 14 days. See, here they took for modified SOFA. They have omitted the neurological criteria from the SOFA score. And the secondary endpoints, they take the patient-centered outcomes like 28 and 90 days survival rates they take, and dose and duration of vasopressors they took, and ICU and length of stay they took. And the explanatory mechanism, because the underlying what things are happening, they try to extrapolate the things by looking the drop height, BNP, arrhythmia and all, and lactate concentration also checked. They try to look the levels of cytokines and CRPs. And the safety outcomes, like every beta blockers, there's a safety outcomes there, and how many bradycardia episodes were there, how many hypotension episodes are there, arrhythmia episodes, they strictly noticed. But unfortunately, the prematurely terminated on December 15th by data monitoring committee by the opinion only during the interim analysis 6 months, 3 months during that period of after the start of study, they have interim analysis have done by DMC, and they have opinion to go for termination because they have found that signal for possible harm and they are unlikely to demonstrate benefit and feasibility of further recruitment, then that unfortunately have been terminated. This is the patient they have been included in the study, but they screened around 4,137 patients, but around most of it, like 3,700 has been excluded due to lot of reasons, have been excluded from the reason. Then only 348 was eligible, but unfortunately more than 200 patients had declined for giving participation. And at last, only they got around 126 patients for after randomization. They gave 63 to Landelol group and 62 to standard care. Okay, and like that. And the intervention they did, to the right side of the screen, you can see after randomization, and if the patient have on norepinephrine dose more than 1, and this heart rate is more than 95, then they start a Landelol infusion of 1 microgram per kg per minute and monitor for 15 minutes. Then look for the target heart rate. If it is normal and it is around 80 to 94, there has no change. If it is not improved and heart rate is more than 94, then glandular is increased by 1 microgram per kg per minute every 15 hours till they get a heart rate of around 80 to 90. And it's come down to less than 80, that is they have reduced the Landelol infusion by 1 microgram per kg per minute. But they have done as a careful manner. They have looked at whether this heart rate is not because of other reasons like the patient caring or tracheal secretion. This heart rate can be for this thing they have not given a Landelol infusion. Suppose the patient is receiving Norad infusion and coming down the Norad infusion, and Norad has stopped for more than 12 hours, and the heart rate is getting down or more. Is it getting down? We can reduce the Landelol infusion by, like I said before, they have reduced by 1 macrogram per kg per minute to maintain the heart rate around 80 to 94. And later on, after 24 hours, they have stopped the Landelol infusion if the Norad has stopped for more than 24 hours. With that thing, the baseline characteristics looks almost similar. The average age in Landelol group was around 55.9, and average group in control group was 55.3. The female was similar, 41% in both the groups, and the source of infection is pulmonary is more and abdominal is more, but equally distributed. And received a beta blocker 2 weeks prior in the Landelol group was 14%, and this 16% on the control group. Mean Norad dose was around 0.37 in the Landelol group and 0.36 max per kg per minute in control group. and the outcomes. So mean SOFA score, no difference on the mean SOFA. The landlord group mean SOFA was 8.8 with a standard deviation of 3.9, and standard care of control group 8.1 per 1, and the standard deviation 3.2. The only mean difference of 0.75 with the confidence interval of 0.949 to 0.2. The p-value is around 0.24. Looking taking this Boston-Whisker diagram, we can see that from this chart, after randomization on the start of the study, this mean SOFA is almost equal this thing, and coming down from after this 7th day onwards, there is a big high mean SOFA on the landlord group, but it's not significant. One more thing to notice here, mean number of days from the mean SOFA score was calculated from the randomization was 11 days in the standard group and 7 days for the landlord group. Only 7 days they calculate and this thing. Okay, this again the diagram duplicating the mean SOFA score. What about the study want to say about hemodynamics? Average non-epinephrine infusion on the landlord group was 0.34 max per kg per minute. And 0.24 max per kg per minute in control group. Mean difference is only 0.10. And how about this arterial BP was, you can see this in Boston-Whisker model. We can see that both the group arterial BP is almost similar. The mean is almost similar. And here, coming to heart rate reduction over 14 days in landlord group was 94.4 and 98.6 in control group. So we can see that this is standard, the control standard care and this landlord care. We can see the heart rate reduction was there pretty good in this thing. But again, from this 7th day onwards, there is a correlation of this values. So regarding survival analysis, Cup and Mayer, there is no significant differences there in regard on 28-day mortality. Landlord group was 37% and 25% in the standard care. Though this looks like a difference is there, but unfortunately it's not there. And odds ratio was 0.76% with a p-value of 1.8. Risk difference percentage in 28-day mortality was 11.7%. How about Koch's proportional hazard model for the adjusted hazard ratio was 1.64. Okay, around 90-day mortality, the landlord group was 43.5% and standard group was 28.6% with odds ratio of 2. The p-value is around 0.08. Here the risk difference is 14% and Koch's unassisted hazard ratio is 1.73. Okay, and again there is no change in length of stay and there is no change in mean lactate level measured in both the groups. There has been serious adverse effects in the landlord group. There have been a hypotension around 1% in the landlord group and arrhythmia was around 8 patients in there. And bradycardia was equal in both the groups. On subgroup analysis, again, there is no difference. The subgroup, the analysis is only based on severity of how much they are getting on non-epinephrine. Non-epinephrine less than 0.3 and more than 0.3 max per kg unit. They found no difference between two groups. And patient with the ARDS, they found there is no difference between. And the beta blocker prior have any change in the outcome. They have found no difference in the subgroup analysis. With that thing, how about the study? This strength of study is good regarding this is a RCT. They have a good screening law with a clear guideline to determine the adherence to the protocol. Only 7.7% is not follow the protocol. And it is a good, it is a intention to treat study. It's well balanced baseline characteristics within the two groups. But regarding the limitations of this study, the study tried not to generalize with other beta blockers, but regarding the question that its timing on beta blocker administration is early or too late, we have to address it, and administration also. And they are unable to comment on subject phenotypes, and they have not controlled on the withdrawal of life support leading to death or discharge from ICU. They could have controlled it, both the things. And again, major lack I find in study is lack of echocardiographic finding. And other major lack is early termination may not have sufficient power to describe the clinical effects of the clinical trial. And coming to, if we want to do a post-hoc subgroup analysis also, very few patients left for those. And they have concluded the study, the patient with septic shock did not improve organ function with Landiolol. The study does not support the beta blocker use in the management of the patient with tachycardia on high norepinephrine for septic shock. So, discussion whether this sympathetic overactivity of septic shock, is it treatable pathophysiology or necessary complication, compensation? So, as we discussed in previous lectures, sepsis-induced cardiomyopathy, we know that there is a downregulation of adrenergic receptors, and there is a desensitization of calcium channels at cardiovascular system. So we know that the patient might have 50% of the patient might have left ventricular diastolic dysfunction, and 60% of the patient at day 3, most probably at day 3, will get left ventricular systolic dysfunction, and around quarter of the patient will have right ventricular systolic dysfunctions. Okay. And regarding the beta blocker on immune modulation effects, we see after a sepsis, this is cholinergic system activated, and T cells releases acetylcholine. It acts on acetylcholine receptors on the macrophage that by lead to suppress the release of cytokines and chemokines, thereby reduce the inflammatory response. Coming to the sympathetic system, it have two ways of looking at things. If suppose the beta 2 receptor on the macrophages on activated, they will suppress the release of cytokines and chemokines, thereby reduce the inflammatory. But in fact, if at this alpha 2 receptor is activated on the macrophage, that will enhance the macrophage function. There will increase in the release of cytokines and chemokines. This is illustrated in the paper on Lancet by Immunology. So again, see, sepsis will impair the ventricular arterial coupling. So we know this for good mechanism for arterial ventricular coupling, the EA by ES ratio, that arterial couple elastance and ventricular elastance should be equal to 1. Suppose if it is more than 1, there will be uncoupling. So that means if this aortic or arterial elastance as increases or ventricular elastance decreases, that way arterial ventricular coupling will be more than 1, leading to uncoupling of this thing, and will lead to increase in energy for heart to work. So we have to keep the arterial ventricular coupling to 1. Okay, so that thing we have to need the help for beta blockers. What is about decatecholamine? Sepsis will cause profound overstimulation for arterial receptors. Treating with beta blockers will attenuate the inflammatory cytokines, improvement of cardiac function, and counteract the metabolic dysregulations. Again, the beta blocker will find the tachycardia arrhythmia with the dobutamine infusion. This can be prevented by beta blocker. So, is that any adverse effect with the beta blocker? Study Morali et al. conducted at Italy at around 2013. RCT of 154 septic patient noticed a reduction in the heart rate with preservation of mean arterial pressure and cardiac index. Notice some serious adverse effect like hypotension only in 6%. Okay. And this is another study by Japan. They have landed for sepsis-related tachyarrhythmia, RCTs, in 150 patients. They have not find much adverse effect in these studies. So, looking in a more evidence-based thing, what about this? Meta-analysis, as we discussed previously, this is a meta-analysis in Espinol thing. We can find this diamond is more towards the Espinol group, and the meta-analysis shows a absolute risk reduction and number of patients to be treated to prevent one death is 5.5. Absolute reduction is 8.2. So this is a definitely positive outcome regarding the Espinol. So with that thing, so every patient does not will work the patient, that is sure. And selection of right patient to give better block is good. So in stress cardiomyopathy and dynamic LVOT obstruction or well-resuscitated hyperkinetic patients may benefit by beta blockers. See, in this patient, this is dynamic LVOT obstruction. We can see the continuous Doppler. There is a dragged spectral Doppler that indirectly telling there is a severe systolic anterior mitral valve movement is there, leading to dynamic LVOT obstruction. This patient may benefit by giving the controlling the heart rate by giving the beta blocker. And there is definitely there will be a risk in giving beta blocker, but this can be monitored at the bedside by looking the arterial waveform. We can reduce the after adverse effects and all. See, looking the systolic diastolic notch pressure difference, and this much difference is not there. If this difference is not there, we can risk the patient for cardiovascular decompensation after beta blocker. So I'm concluding with this: controlling the heart rate with beta blocker will maintain the stroke volume. Reduction in the arterial stiffness and arterial elasticity will be there. That will increase the ventricular arterial coupling. Selection of the patient by advanced hemodynamic monitoring and echocardiogram may be useful. That is doubtful. We will discuss in further discussion. Thank you. Over to you, sir.
Thank you, Dr. Ajmal. That was a very elaborate discussion of the study. And of course, you have touched very important points, and still we are left to discuss some of the important conclusions which have been drawn from this study. And this study is up for dissection now. And today we have been joined by a lot of viewers from Indonesia, and they have a lot of important, interesting questions to ask. But before that, since those questions pertain to the use of beta blockers as such, so first we are going to discuss and dissect this study on the basis of the observations and conclusions, and then we will take up those questions. Now, quickly, I start with our expert panelist, Dr. Ramesh, and I will ask Dr. Vijay the same question. When we are talking about a drug, nadiolol, which has 8 times more affinity to the beta-1, and yet we are not seeing the result that was seen with esmolol when we particularly look into the large study, the Morelli study. So when you think about the primary outcome which has been taken here in this study, that is the SOFA at 14-day, not anything else, SOFA at 14-day. We know that a patient who is being discharged from the ICU won't have a SOFA. A patient who dies doesn't have a SOFA at 14-day. How well do you think is this primary outcome to decide on the fate of a drug? Dr. Ramesh.
Sir, in Morelli et al. Study, there were few caveats in that, because in that control group was having more sicker patients, and second one was they used randomly levosimendan based on the oxygen SpO2, and other thing was the study was not designed to prove the mortality benefit in that, and the power of the study also was not so great to prove that the mortality benefit and all. So apart from that, what we can see is there are 2 studies which were withdrawn suddenly in between interimly. One is Japanese study and second one is this study also, what we are discussing, stress and study. Because of the adverse effects in the Japanese study, almost one patients among the 10 patients were having the adverse effects like hypotension. One patient had went into cardiac arrest also. So those were the things. And coming back to laryngeal, what were the main thing what we want to prove was the pathophysiological benefits, like cardiac benefits of reduced oxygen requirement of the heart, all those things and that. But having said that, when we see the cardiac function wise regarding this study, they didn't assess the cardiac function either by DPDT, by echo, or invasive cardiac output monitoring, assessing the stroke volume, all those things.
I will come to, thank you. Dr. Ravish, I will come to that. I want to ask Dr. Vijay on that account. From the similar, I can understand from the author's view that it is sometimes difficult to calculate calculate the sample size and determine on the basis of effect size estimate for mortality, especially when there is not good amount of data. That's why probably they didn't choose mortality as the primary outcome. But how do you think is the SOFA at day 14 a primary outcome for such a study of such a big magnitude, especially where we have seen that large number of patients who have been screened are actually not participating in this study? Do you think some different primary outcome would have been a better approach? Dr. Vijayan, you are muted.
At first, thank you, Dr. Anirban and organizers for having me here. And Dr. Ajmal had done a very elaborate dissection of the study. And the previous speakers have spoken on the different studies, and the most of the studies were having a heterogeneous population. And compared to the previous studies, one of the advantage of this study is that the population was almost homogeneous. And as they said and pointed out, that the major drawback of the study is that an echo was not done before this during the recruitment of the patient, which might have which would have been better if the echo was done. Now, it is very difficult to have a mortality comparison with a study of this sort. And I think the severities, that is the reason why they have chosen the SOFA scoring as one of the primary outcome. But again, this SOFA, you are using a modified SOFA score. And I think that should be an adequate for the looking at the primary outcome measures.
Fair enough. Dr. Pradeep, I want to ask a very important question, that when you see the two groups of patients, the landiolol versus the standard of care group, you see that these patients had, in the landiolol group, had an increased requirement of norepinephrine, number one. These patients have a higher lactate, number two, which means that their cardiac output was already reduced. So therefore, do you think a proper cardiac output monitoring should have been done in this study to give more?
Thanks, Anirban. Absolutely. I think as the previous esteemed panelists have alluded to, Deepak, and even the authors do say in the limitations that they did not do cardiac output. Because if you see the earlier evolution of the studies, because when I was reviewing the literature, Anirban, I was quite ecstatic that there is so much of compelling evidence that was built prior to this trial. And all those previous studies, which Ajmal fantastically presented, they all looked at cardiac output variables in some format. They looked at lactate, they looked at SCO, mixed venous oxygen, and so on and so forth. So definitely that was a limitation. Another important limitation, Anirban, is the mortality. Although this study, you can tout it as being robust, surprisingly, authors do say that mortality was very much less as compared to the standard mortality reported in a good sort of a big database, like say, sepsis 3 database. If you look, the mortality was 42%, but here it was only 25 to 28%. That itself shows, had they taken little less sicker patients, I don't know. And even the Cochrane review showed mortality of 38. Here it was much lesser, 25 to 28. So those are some of the reasons why possibly we did not appreciate the type of effect we would have expected.
Ajit, when it comes to mortality, when you look into the figures, the secondary outcome, the 28-day mortality versus the 90-day mortality, you find that there has been an increase in this hazards ratio I mean, the odds ratio from nearly 1.76 to 2.04, something like that. So do you think that in spite of the fact that mortality here is a secondary outcome, that is, the sample size is not calculated or the study is not designed to calculate the actual mortality, but yet this study indicates that as time progresses, those who are receiving this drug, nadolol, are more likely to die? Does it mean that way, seeing the jump in the numbers from 28-day mortality to 90-day mortality? Dr. Ajit. I think Dr. Ajit has missed. He is probably having some internet problem. Well, Dr. Ajmal, I'll go to you for the same question. If you see the secondary outcome, since you have gone through this study, you have definitely observed that the jump in mortality from 28-day to is alarmingly high. And therefore, does it mean that the mortality is definitely going to increase, irrespective of whether you have rightly calculated the sample size or not?
Can you hear me?
Yes. Yes, sir. Yes, sir. Even while
Ajit
looking
has
to
come
the
back, Anirban. Yeah, Ajmal, after you. You finish, Ajmal.
After that, I will go. Yeah.
So by looking the Kaplan-Meier also, we can have the impression that it's so much wider the gap is. Then, but they have only the Cox ratio have been putting them. That's not significant that maybe some the more the sicker, I mean, like the days progresses after 7 day onwards, the beta blocker might have a negative impact on the patients. But the Cox impression they have done unadjusted and adjusted ratio, and this then have put the two, but that is not significant themselves. But by looking the Kaplan, we can clearly say that is some difference is there.
Yeah. Ajit, I want to ask you one simple question. One is that this study,
Sorry. Yeah.
This study has shown that although there has been no difference in adverse events, by adverse events they mean more than one adverse events in the two groups, the risk of serious adverse events was consistently was much higher in the landiolol group. So do you think that this could only have been proven in a better way if they had a more structured, time-bound, time-limited way of detecting serious adverse events rather than terminating the study midway? If the study would have continued till its full length, who knows? This could have been just reversed, like in any T20 match.
Yes. So that's the thing. So basically, as we already mentioned, because the not doing an echo, we never have an idea about how the cardiac functions were there. We never know how we have been, because the echo has not been done, the cardiac evaluation was not done. We have been unable to identify how the cardia would have worked in contributing for the shock, and finally what happened to the patient's outcome. So it's difficult to comment, because that is one of the drawback of this study. So naturally, it is difficult to comment about that at this stage.
Dr. Ramesh, I go to you. Another important question, that when we see that the effect which Dr. Ajmal had wanted to highlight was also on the basis of the immunological problems, that is, the beta blockers seem to suppress the immunological effects or the immunological mechanism to an extent that it produces a state of immunological tolerance. Now, if you think in terms of the real benefits of the immune system in sepsis, at least in early stages of sepsis, do you think that this is truly an adverse effect or a beneficial effect?
Yeah, when we have a patient with severe septic shock, there is an involvement of multi-organ involvement also, which is partly because of the immunological mediator which they release. And in previous evidence also clearly shows that landiolol will reduce the IL-6 tumor necrosis factors and IL-10 also to some extent. As Ajmal has described before, beta-2 agonistic activity will suppress the immunological response, and alpha-2 agonistic activity will enhance the immunological response. Since it is a beta-1 selective, beta-2 agonistic activity is still there, I think. So the evidence also, when they monitor the levels of tumor necrosis factor and IL-6, they showed that there was a reduced levels of tumor necrosis factor and IL-6 with the use of nadolol.
Well, I will take some questions that we are getting posted by our viewers. I go to Pradeep first. Pradeep, I have getting a lot of questions asking about the timing and indication of beta blocker in septic patients. Would you like to comment on that?
Yeah, I think that's a very good question. So because most of these earlier studies, Ajmal can correct me, they have suggested to initiate beta blockers after good hemodynamic optimization addressing the cardiac function. Because if hemodynamic optimization with whatever fluid status and vasopressors has not happened, then you start beta blockers. Because if you see how the evidence has evolved, initially all the studies showed that you start beta blockers, it causes drop in the cardiac output. But then later on, they showed that the initiation of the ultra short-acting beta blockers like esmolol improved the stroke volume and cardiac output. So what that means is maybe the better optimization was happening with fluids and vasopressors, and then this ultra short-acting esmolol was started. So that's where they saw the effect. So optimization becomes terribly important. Obviously, you wouldn't embark on starting this when someone is hypotensive and not hemodynamically optimized. Maybe Ajmal can answer, add in few comments, and then you can move to the next question.
You have answered that.
Not only that. See, you are starting the beta blocker, after 24 hours after noradrenaline, and obviously all the we talk about the organ crosstalk and all this might have already happened. So I think it should have been much earlier, right? At least even before the septic shock happens. Septic shock, obviously the organ crosstalk has already happened. Then that after 24 hours you are giving, I think it should have been given a much earlier time. That's what I presume. Yes.
Fair enough, Ajit. I go to Deepak Vijay. I will frame it in an easy way for Dr. Deepak. We all know that agonist action, beta agonist action, is going to improve the cardiac output. It is going to reduce the oxygen demand and do all the good things. Whereas excessive agonist activity would again increase the heart rate, which would reduce the diastolic filling, which would reduce the coronary perfusion, which would increase the cardiac work and all this. Now, when do you think, when is the right time to assess a patient that whether the patient is going towards increased activity where you need to put a halt by using a beta antagonist or beta blocker, selective beta blocker, or you allow the patient with the beta agonist so that the same can be achieved, that the real purpose? When is the right time in a septic patient to determine that? The studies have shown 24 hours. We are not sure. Some people say 72 hours. We are not sure. But it is, even if it is difficult to set a clear-cut timeline, but when is probably a good time to decide whether this increased sympathetic activity should continue or whether it should be halted? Yes, Dr. Vijay.
Yeah, we all know that the sepsis causes an increase in sympathetic activity, and during the initial phase of sepsis, there will definitely be sympathetic overactivity, and I think we should not abolish that with the use of beta blocker, even though there is no evidence on the timing of beta blockers in the sepsis. Generally, I can say that once the resuscitation is over, if the patient is adequately filled, maybe in the once this inotropes are started, and if still the patient is having a hyperdynamic circulation with increased heart rate, and after an echo, probably you can start on beta blocker, but not in the initial phase. That is my take on this.
Quite enough, fair enough. Dr. Ramesh, I want to ask you another question which our viewers have posted, and that is how to choose the right time and the right type of beta blocker, one, in patients with asthma, and number two, patients with pre-existing cardiac disease.
Yeah. So pre-existing cardiac disease, once we assess by an echo, if the patient is having low ejection fraction, we should not use. It's clearly mentioned in the evidence also, which shows that when they categorize the patients into low cardiac index and low ejection fraction category, those are the patients who will have a harmful effect when the beta blocker is used. Coming back to asthmatic patients, better to avoid beta blockers because of the bronchospasm. And before starting a beta blocker, we have to see the patients like what we are discussing, like echo, DPDT and all. If the DPDT is after using the beta blocker, if it is reducing, better not to use because it reduces the contractility of the heart. And what is the other question, sir? Sorry.
No, these are the two questions. I go to the second part of the question. I will ask Dr. Ajit into it, that they have asked question about bisoprolol. So do you think that what specific type of beta, what is any particular type of beta blocker that should be preferred over the other. We all prefer the ultra short acting like esmolol because we don't have landiolol in India. But what do you think about bisoprolol or any such other beta blockers? Yes, Ajit.
Yeah, maybe more cardiac specific and less going to be affected by the beta 2 the receptors. So maybe a potential, but again the risk is the lowering the blood pressure, because when the patient is septic shock, when you go for any kind of a beta block, including bisoprolol as well, because there is a risk of worsening of the shock is expected. So
Yes.
it requires a lot of monitoring. I think that could be one reason in at least the earlier trials, many of them showed, some kind of increased mortality within the beta blockers. So it is better. The ultra short acting maybe is a very transient action, The other beta blockers, always the risk of, the lowering BP in an already, shocked patient. That can happen.
Ajmal, there is a question from Juliana which asks that, can we use such beta blockers in pediatric patients? I think it's a difficult question to take for on, but still I would go to you that whether you have read in the literature, even if not have experienced on their use in pediatric.
There have been like case control studies are there, but it's not extrapolated in this thing. And it's said in pediatric beta blocker burns patients, pediatric beta blockers have case series have shown a good results. In septic shock, there is not more studies are there. Again, with hemodynamic study, echocardiography, if the patient is hyperdynamic heart showing the echo after properly filling the heart, we can take on beta blocker because it's in burns it is using safely.
Fair enough. Dr. Vijayan, one question has come from again another one of our viewers from Indonesia who wants to know what are the indications for beta blocker for sepsis. I think we have discussed it quite a bit, but we have quite, if you just can enumerate them numerically, 1, 2, 3, 4, it will be easy for her.
Yeah. The first thing is when there is a ongoing sympathetic overdrive, like even after the fluid resuscitation, the sympathetic system goes on overacting, then you should screen the patient with an echo, and then you should, if there is no LV dysfunction at all, you can very well start on beta blocker. And second thing is in a patient who is adequately fluid filled, and if there is still an ongoing tachycardia, to reduce the heart rate, which improves the coronary perfusion, you can start on beta blocker. And the third thing is, as Dr. Ajmal had pointed out, in stress cardiomyopathy also there is a role for beta blocker. But the timing of beta blocker is still, we do not have a strong evidence on it. And in general, I would say that once the initial fluid resuscitation is over, still the patient is having hyperdynamic circulation, and if the echo doesn't show anything contraindication to the beta blocker, then you can consider the beta blocker therapy in sepsis.
Fair enough. We are left out of time. I will go through 1 or 2 questions before I go on to all the participants, for all the panelists for their take-home message. I want to ask Pradeep that there is a question coming from Asaduddin again, that should we use beta blockers directly when HR increases, or should we treat other causes like pain, etc., before starting the beta blocker use?
Yes. So, Anirban, as the evidence points out, I think it is more to do with addressing the heart rate. So when I was just reviewing the literature, again, the interesting analogy starts. What is the role of ivabradine in all this? So on and so forth. So because that raises another whole context altogether. So I think the whole question is, Anirban, if someone is already on beta blockers, already pre-existing, so I think there is a good body of evidence which say that this is the phenotype which tends to do well. And whether I continue those beta blockers in this group, because if you have to go by the first study, continued beta blockers, they showed actually remarkable favorable benefit. Maybe as all the panelists agreed, after good hemodynamic optimization, after their euvolemic, I may maybe now I'm compelled to consider continuing some sort of a beta blocker, because there is the good evidence that someone who is on beta blocker, the outcome seems to be better. So that is something I may keep in back of mind.
I fully agree with you. Pradeep, you can finish. You can finish your sentence.
Yes, that's about it, Anirban. Yeah,
so that's what I just said, but definitely there is a rationale in believing that the pain, etc., or if there are any other causes which is causing the sympathetic drive, which can be reduced through the use of analgesics or sedation, etc., should be attempted before using beta blockers. That goes without saying. So since we are already short of time, I will go to each of the panelists to like, what do you think is the key message that culminates from this entire exercise, from this whole study? I will start with Dr. Ajmal, who has presented today. Dr. Ajmal.
Indeed, a good trial. It has been carried out in a good manner, but unfortunately it's underpowered. Again, we have to look the patient clinically and set the phenotype is there, it is properly filled, and if we are facing a hyperdynamic circulation due to sympathetic overactivity, with the hemodynamic evidence and echogram, we can try with beta blocker, but be cautious with it should not have harm the patient.
Absolutely. We try first, we do no harm. That should be the motto while using this drug. Dr. Vijayan, the key message that emanates from this study.
My take-home message would be that the current evidence do not support the use of beta blocker in septic shock. And in a very few selected patients, you can consider beta blocker after doing a hemodynamic assessment.
Dr. Ramesh.
I think larger RCTs are required to prove the effect of this. I think till now the evidence is completely contrast with few studies going positively and few are negative. I think excluding the patients and including properly with the timelines after 24 hours inclusion and removing the patients for having RV dysfunction, LV dysfunction, all those things.
So a cautious approach, that's what you recommend, a cautious approach, right?
Sure.
Dr. Ajit.
Yeah, in my practice, I don't use beta blockers in septic patients at this point of time. And in this trial, the potential harm which has been in the landiolol group is again it is very debatable unless and until further more robust trials with better evidence, more concrete evidence comes in. I will not be using beta blockers in my practice. And obviously, as Dr. Pradeep has mentioned, I'm looking forward to some certain drugs like the ivermectin. Maybe we can just
I think that's a very candid
decrease the heart rather than which won't cause hypertension. He's looking forward to some kind of a result from such studies and looking forward for future. But at this point out of my design, alter my practice.
I can understand, but even with ivermectin with the 5 mg dose, also there has been considerable differences because the effect can last longer in some patients and can wane off very easily in some. So that has been a point of discordance at many studies. Dr. Pradeep, what is your final take-home message from the study?
Biased opinion because when I reviewed the whole sea of literature, there are 8 randomized controlled trials, 4 meta-analyses, 6 studies, and a good number of studies in pre-existing beta blockers. There are 4 big studies which said someone who is on a pre-existing beta blockers. So I tell all my trainees the first choice for blood pressure control in ICU will be beta blocker, which has always been for me for many years. So that will remain. So someone who is already on beta blockers, who's fully optimized hemodynamically, if they are tachycardic, Anirban, if they are more than 110, I may be compelled now to consider using ultra short because this is study, mind you, with because all the studies was with esmolol. So I'm still uncertain that we may be missing out on some beneficial effects and putative effects. So I may consider in a select group of patients, especially where tachycardia is persisting despite volume resuscitation, optimizing volume and assessing hemodynamic status, assessing the cardiac function, I may consider Anirban.
So differences opinion can persist for yet another time till we get more evidences, more concrete evidences and more evidences that stands to the test of time to believe that beta blockers are truly useful. But yes, they can be used in situations where other measures fail to control the heart rate and where the increase in heart rate is a problem for the patient, both in terms of oxygen demand, the coronary perfusion, and a reduction in an increase in the cardiac work. But even then, you should admit that these tachycardia might obtend whatever remaining evidence of sepsis may be there in a patient by the use of beta blockers, and vital important informations can be missed too. So on a note that we need to make a cautious use of beta blockers, and yes, they can give some benefit in some patients, but yes, we need more studies to find that out. Wish you a very, very, very happy Deepavali until we are back again with yet another episode of article or a journal for our next rapid journal review of the GICS. From all of us in the desk, Shubhratri, Shabar Khayat, good night.
Thank you. Thank you.
Thank you. Thank you. And thank you all the panelists for taking your time out. Thank you.
Thank you so much, and happy Deepavali greetings from Trivandrum.
Thank you, Ajmal.
Thank you. Happy Deepavali to Dr.
Thank you, sir. Thank you, sir.
Happy Diwali, sir.